Welcome to the third lecture of the hematology series. The topic I'm going to discuss today is about lymphomas. Now, lymphomas are not very common group of diseases. I would say they are rare. But the reason why we decided to include this to the lecture series is because the one thing is they have a very unique set of clinical features. The second reason is, like in the previous topic, here also the presentations are with very common symptoms. So it's a rare presentation of common symptoms, and if you miss, it can cause disastrous consequences. So lymphomas are malignancy of lymphoid tissue. By definition, it's an abnormal clonal proliferation of lymphoid cells of various degree of maturity. It is a diverse group of disease and it can arise at any site where lymphoid tissue is present. Now, what are the sites where you get lymphoid tissues in the body? Firstly, lymph nodes, and then you get the lymphoid organs like liver, spleen, tonsils, adenoids, pharyngeal ring, we call it Waldeur's ring, and also bone marrow. And also, if you can remember your anatomy, there are lymphoid tissues in the other organs as well. Now you know in GI tract, the wall of GI tract, you get the lymphoid tissues, and then genitourinary tract, skin, sinuses, thyroid, and CNS. So, lymphomas can occur even at any of these sites. And also, if these abnormal lymphoid tissue spill into the blood, we call it leukemic phase of lymphoma. Now, basically, there are two types of lymphoma, that is Hodgkin's lymphoma and non-Hodgkin's lymphoma. So, Hodgkin's lymphoma is a B cell. You know, there are two types of lymphocytes, B and T. So, it's basically a B cell lymphoma, whereas a non-Hodgkin lymphoma could be either B cell or T cell lymphoma. Thomas Hodgkins, a curator of the Anatomy Museum of Guy's Hospital, London, has found several anatomical specimens like this in his anatomy museum, where several specimens of young boys with this type of gross lymphadenopathy. So he studied further and then he described the Hodgkin's type of lymphoma. So it's a malignancy of B cells, and the interesting thing is it's a potentially curable disease. So if you detect the disease early, you can cure the disease. And if you can remember your pathology, it is a histological diagnosis which is assisted by some unique clinical features. The histological cell that is required to make the diagnosis of Hodgkin's lymphoma is Reed-Sternberg cell. It is common in males and it has bimodal distribution. That is, one group can occur in younger group, especially in males, that is 15 to 30 years, and then there's another group occurs in older age group. Okay, unlike in other malignancies, lymphomas have shown some etiological factors. Now, if you take the Hodgkin's lymphomas, Epstein-Barr virus has been recognized as an etiological factor because up to 40% of patients are positive for EBV antibody. In addition, Hodgkin's lymphoma is high in incidence in patients with HIV positive patients, and 1% of these patients have positive family. Now, what is the WHO classification? So there are two types. The first one is classical Hodgkin's lymphoma, which comprises of 90 to 95% of cases. In this group, the hallmark of diagnosis is the classical Reed-Sternberg cell. And what is Reed-Sternberg cell? It's a large abnormal lymphocyte. Where do you find these cells? They do not find in bone marrow, but they find in the affected lymph node. So it is a cell that is found in lymph nodes. It's a large abnormal lymphocyte. The classical appearance is it could be either multinucleated or they have bilobed nucleus like this nucleus with prominent eosinophilic inclusions like nucleoli. Now you can see prominent eosinophilic nucleoli. So it has this classically described as owl's eye appearance. So this is the classical cell to say that that a patient has got Hodgkin's lymphoma. So now these names, it's good to know because a lot of diagnosis cards you will get this type of names. So there are four types. The commonest is nodular sclerosis, which occurs in 70% of cases, and it's common in young adults, and the prognosis is also good. The second commonest is mixed cellularity. The third one is lymphocytic predominant. The fourth one is lymphocytic depleted. So I said there are two groups, the one with the classical Reed-Sternberg cell. Then there is another group. They do not have this classical Reed-Sternberg cell, but they have a variant called what is called popcorn cell. That group is called nodular lymphocyte predominant lymphoma. So there are two groups of Hodgkin's lymphoma, classical and nodular lymphocyte predominant lymphoma. Classical group, there is Reed-Sternberg cell, and then it has four groups, and these are the four groups. So the clinical presentation is the most important part in this. So the classical presentation of Hodgkin's lymphoma is a disease of lymph nodes. So the classical presentation is lymphadenopathy. Now we know there are now when we do the general examination, we check for cervical, axillary and inguinal lymph node. But you should remember there are several lymph node groups in the body which can be examined or can be diagnosed by doing various investigations. Now if you take the cervical, in the neck you get cervical, supraclavicular, occipital and preauricular. So these groups are important for the diagnosis and the staging of Hodgkin's lymphoma, right? So if you take them as well as you get the infraclavicular nodes. So then you get axillary and pectoral group and the inguinal lymph nodes. In addition, you can examine the epitrochlear or bronchial lymph node. Now this is very important because the reason is now some time ago we encountered a young boy with PUO, and the only physical sign was he was having this epitrochlear lymph node enlargement, and he was found to have Hodgkin's lymphoma early stage. So it is important to examine this lymph node group as well, and then even the popliteal lymph nodes also you can palpate. For the other nodes like mediastinal, para-aortic, iliac and mesenteric, you have to do X-rays, radiological investigations, and you can feel the spleen and liver as well. So the lymphoma can occur in any of these lymph nodes. So if you describe this lymphadenopathy further, the the classical appearance of the Hodgkin's lymph node enlargement is described as painless, rubbery, firm, asymmetrical, non-erythematous, non-tender lymphadenopathy. So if that appearance is there, um, it is said that it can be considered as hallmark of the Hodgkin's disease. Sometimes they could be matted. It is common above the diaphragm that in 80% of cases, and most commonly affected lymph node group is cervical nodes, giving the classical bull's neck appearance. Now remember these two pictures, so you know these are two patients with Hodgkin's lymphoma having the classical bull's neck appearance. And the interesting feature is there, they become painful after drinking alcohol. So this is also a very important physical sign or symptom that will point towards the diagnosis of Hodgkin's lymphoma. You should ask this in the history. The second important physical sign is fever. So either they present with lymphadenopathy or fever. Now fever or PUO. So these are very common symptoms, and so classically the fever we describe the fever of lymphoma as a Pell-Epstein fever. That is, you get fever for a period of 3 to 10 days, followed by a period of afebrile for about another 3 to 10 days, and then you get another fever period of fever for the same duration. So this is the classical but not the commonest presentation, so which is called Pell-Epstein fever. And also it is generally associated with profuse sweating and sometimes drenching night sweats like in tuberculosis. So it comes in the differential diagnosis of TB as well. Another interesting physical sign is pruritus. So these patients have pruritus in 25% of cases. So it is a common presentation, and when they have pruritus, it is generally severe. So lymphadenopathy, fever, night sweats, pruritus. And also a weight loss is also a very significant clinical feature in these patients. And they also present with other constitutional symptoms like fatigue, weakness, tiredness, cachexia. So they will have these features as well. So if you have fever more than 38 degrees centigrade, drenching night sweats, or loss of weight more than 10% of body weight within previous 6 months, these symptoms are called B symptoms. The name given for these symptoms are B symptoms. This is very important in the classification or staging of Hodgkin's lymphoma. So fever more than 38, drenching night sweats, more than 10% of body weight loss within the 6 months are called B symptoms, which are present in 25% of patients. Now you will realize why these things are important in subsequent when I discuss the subsequent. So what are the other physical clinical features? Now I said it can affect the other lymphoid tissues. So they can present with splenomegaly commonly, and or hepatomegaly, sometimes splenomegaly or hepatosplenomegaly. And you get mediastinal lymph nodes. So if this mediastinal involvement is there, they can present with either cough or sometimes a medical emergency, that is SVC, superior vena cava obstruction. So this is one of the dreaded presentation of lymphoma, especially Hodgkin's, because it affects above the diaphragm. And then interestingly, they can also present with CNS manifestations. You know, any malignancy can cause paraneoplastic syndrome. So they can present with any paraneoplastic syndrome involving CNS. Also, this lymph node can cause compressive neuropathy. So they can present with, if it is like trochlear node, then epitrochlear node, they can present with ulnar nerve palsy, or any nerve compression. If it's femoral, then they can present with femoral nerve palsy. So any compressive neuropathy, or sometimes they can present even with Guillain-Barré syndrome or meningitis like syndromes. And renal involvement, this Hodgkin's lymphoma can be present as minimal change nephrotic syndrome. So these are the unusual presentations of Hodgkin's lymphoma. Commonly, fever, night sweats, weight loss, pruritus, and lymphadenopathy. Right. Now, about the staging. Now, why you should know about the staging is, now you all are not oncologists, you are not going to manage these patients, but when you work as house officers, you might see diagnosis cards saying Hodgkin's lymphoma 3B, 3BE. So you should know, they will not describe what is 3BE. Then you should know what type of patients you are dealing with. So that is why you should have a vague idea about the staging of Hodgkin's lymphoma. So it is, now the staging is based on the fact that the lymphoma, Hodgkin's lymphoma, classically spread in orderly manner, right, with involvement of contiguous lymph node group, right. So if this patient first to present with cervical group, say supraclavicular group, then the next lymph node involvement would be either the same group of cervical, like either intraclavicular or occipital group. They do not skip the intraclavicular and go to the inguinal group. So it's spread in a very orderly, contiguous manner. So one group to the other, right? And but the currently available the staging system is modified Ann Arbor staging system. So when we were medical students, it was Ann Arbor system. Now it's called modified Ann Arbor system. So here, if I simplify what is in this slide, now there are 4 stages in Ann Arbor classification. The stage 1 is either single lymph node or single lymph node region. So if you take axillary group, so the axillary group is involved, right? So one lymph node or one lymph node group involved. Stage 2 is either 2 or more lymph node groups involved in the same side of the diaphragm, right? So in stage 2, the patient will have cervical as well as axillary. So one side of the diaphragm. Stage 3 is involvement of both sides. So there is cervical, axillary and iliac group. Stage 4 is, it is disseminated disease. So stage 1, single group. Stage 2, more than one, same side of the diaphragm. Stage 3, both sides of the diaphragm. Stage 4 is disseminated group. So this is the diagrammatic representation. Stage 1, one group. Stage 2, more than one in same side of the diaphragm. Stage 3, both side. Stage 4, disseminated disease. So in addition, they have further classified the disease as A or B, that is stage 2A, stage 2B. depending on absence or presence of B symptoms. So if this patient has, in addition to this lymph node involvement, if that patient has got B symptoms, that is called stage 2B. If no B symptoms, you know what is B symptoms now, that is 2A. And then they put E if there are involvement of extra lymphatic sites. So if the splenomegaly is also there, they put E. And if it's bulky disease, X. So when you see a diagnosis card, when a patient presents with diagnosed patients with Hodgkin's lymphomas, so if that patient's diagnosis card has these abbreviations, you know now what they mean. So just better to know what these the abbreviation means. So what are the investigations you know? So it's a malignancy. So the ESR will be very high in patients with lymphoma as well as CRP. And also ESR is important. It can use to monitor the, when you treat the monitor to response of the disease also you can use ESR. And what are the features in full blood count, right? So full blood count, you can get anemia, normocytic normochromic anemia because of the anemia of the chronic disease, right? So, so in addition, if there is bone marrow involvement, you can get leukoerythroblastic anemia. And also, there's a deranged abnormal cell-mediated immunity. So, there is eosinophilia. And because of eosinophilia, the neutrophil count will be high, right? Okay. And then you might think because it's a disease of lymph nodes, you can get lymphocytosis, but it does not happen. Actually, what you get is lymphopenia, especially in advanced disease. So if you do a full blood count, the abnormalities would be normocytic normochromic anemia, non-specific, eosinophilia. If there's eosinophilia with these symptoms, that might suggest that this patient has got lymphoma, and also lymphopenia in advanced disease. If you take platelets, it could be normal or increase in early disease and reduce in late disease. Now remember, if you do blood picture, now this is not a disease of blood. It is a disease of lymphoid tissues. So generally blood picture will be normal, but you can get pancytopenia if there is bone marrow involvement. So it's not helpful. So there's no point doing blood picture if you are suspecting Hodgkin's lymphoma unless that you're suspecting bone marrow involvement. So the further investigations I will explain later. Now, how do we diagnose? Now, to diagnose, you need the history and thorough clinical examination, right? So, there should be fever, there should be night sweat, pruritus, alcohol-induced pain, they might say lumps, and then you have to do a thorough clinical examinations including all the lymph node group examinations as well as the examination of Waldeur's ring, that is you have to look for the tonsillar enlargement as well. So, and the definitive diagnosis is you need a excision biopsy of the affected node. You don't, the needle biopsy is not helpful because you have to demonstrate the classical Reed-Sternberg cell in the lymph node. Now further investigations are required for the staging. Now you know I have given the various type of staging. So certain features are obvious in clinical examination, but the features like mediastinal or para-aortic nodes are not obvious in the clinical examination, and for that you need the radiological investigations like chest X-ray, CT, chest, abdomen, pelvis, neck, and MRI scan. Now this is a chest X-ray showing mediastinal widening and also the mediastinal lymph node. And this is a X-ray showing para-aortic lymph node enlargement. Sorry, CT showing para-aortic lymph node examination. But in certain instances, especially not in Hodgkin's, but in non-Hodgkin's, if there is intestinal involvement causing narrowing of the intestine, sometimes MRI is helpful, and certain areas where you can't see the area in CT, the MRI also indicated. Now, PET scan is very useful because now if you look at this picture, now here the chest does not show any abnormality in CT, but PET scan shows several focus of lymph node enlargement. So it is, if it is available, it is very useful investigation for staging of Hodgkin's lymphoma. And bone marrow biopsy should not do routinely. It is if there are features suggestive of marrow involvement, and also patients with advanced disease, stage 4, and patients with B symptoms. Generally, they say if the patient has B symptoms, the prognosis is poor. So you have to look for bone marrow involvement, and especially in patients with HIV positive. So for etiology, EBV serology and HIVs. And there are certain investigations required for the management of this disease. Now you know these patients will be treated with various chemotherapeutic agents which are cardiotoxic, liver toxic and renal toxic. So before you start treatment, you have to do the liver, renal and cardiac profile, and as well as there are certain drugs like bleomycins can cause pulmonary fibrosis. So it's important to do respiratory functions. And serum uric acid is important to see whether the patient has got a complication called tumor lysis syndrome. So sudden lysis of areas of tumor mass can increase the uric acid. So this is also very important. LDH again indicate a cell lysis, and serum electrolytes is also important. And then the radiotherapy. So these patients sometimes are treated with the radiotherapy. So you have to discuss and assess the fertility of the patients as well. So I'm not going to discuss the management in detail, but then you should have a brief idea. Now the aim of this management in lymphoma, although it's a malignancy, it's a curative management. Now remember, there's nothing called palliation in Hodgkin's disease unless it's really advanced disease. So the management is curative. So the basic regime is what is called ABVD. A for adriamycin, bleomycin, vincristine and dacarbazine, right? And then this is the classical chemotherapeutic group, just remember. And then there are different regimes for aggressive disease. So then if there is localized disease, you can give involved field irradiation, and then you can use rituximab. This is the newer form of management in Hodgkin's disease. And the frequency of giving rituximab as well as the dose is depending on the stage of the disease. And the curative treatment you can use as a curative treatment, hemopoietic stem cell transplantation. And then if you take the supportive management, the vaccinations you have to do because these patients are immunocompromised, but avoid live vaccine. And if there are like compressive lymphadenopathy, you can do surgery. Right. Now, even if you remember everything so far I said, please don't remember this. Please don't forget this. Now this is a dreaded complication of the Hodgkin's lymphoma that can kill a patient, and it is often first encountered by a house officer. That is superior vena cava obstruction. So I hope you know about this. If you do not know, make it a point to read about SVC obstruction today. So they can present with dilated veins in the superior vena cava distribution, and they have edematous face, they have breathing difficulty. So you have to identify this problem on admission and inform the seniors, because you have to treat it before some dreaded complication can occur. And the other thing is the infections. And then I will just go through, then there are some complications of treatment, like patients can, when you are a house officer, when these patients can present with these complications like short-term hematological toxicity. They can come with anemia, which you have to treat with transfusion, and then sometimes febrile neutropenia you have to diagnose and treat. And bleomycin and thoracic irradiation can cause pulmonary toxicity, and anthracycline can cause cardiac toxicity. Long-term complications, they can come with another type of malignancy like myelodysplasia and acute leukemia, and they have a sometimes increased risk of lung cancer or pulmonary fibrosis. And also long-term risk of infection is high if we manage these patients with splenectomy, but it's no longer, it's very rarely done in the current practice. So good to know about these long-term and short-term complications as well. But please don't forget superior vena cava obstruction. And then also they can come with secondary cancers. They have found patients who have been treated with mediastinal eradication can come with breast malignancies and lung cancers in smokers, chemotherapy-induced neuropathy, and psychiatric and anxiety-related disorders, and infertility. So you have to address, these are young patients, you have to address and discuss about the fertility before you start. Right. So that is for the Hodgkin's lymphoma. Then we will move on to the next group of lymphoma, that is non-Hodgkin's lymphoma. So it's a large group of disease, and it arises from mature B lymphocytes commonly, and rarely also it can occur in T lymphocytes as well. So this is a rare kind of disease, but it's commonly B lymphocytes, but rarely it's either T lymphocytes or killer cell. Now remember, Reed-Sternberg cell is classically absent in non-Hodgkin's lymphoma. That is why it's called non-Hodgkin's, and usually as opposed to the Hodgkin's lymphoma, this can occur in the older age group. Now this slide illustrates all the groups of disorders classified under the large group called lymphoproliferative diseases. Now if you look at this circle, it illustrates that the highest or the largest number is because of non-Hodgkin's disease comprises more than 60% of lymphoproliferative disease, which is followed by plasma cell disorders, myeloma and other diseases, which I have described in my previous lecture. And then Hodgkin's disease comprise of 8.2%, which is followed by the hematological lymphoproliferative diseases, that is chronic lymphocytic leukemia and acute lymphocytic leukemia. And if you take a non-Hodgkin's lymphoma, it is a general term given to a large number of diseases. So there are about more than 20 diseases which is grouped in the broad group in non-Hodgkin's lymphoma. This is another slide just to see the number of diseases in the group of non-Hodgkin's lymphomas. This is just for reference only. Please don't read and remember all these diseases. So the basic classification is aggressive lymphomas and indolent lymphomas. So aggressive are called high grade and indolent are called low grade. Now if you discuss further about these two groups, just remember now you will come across these names: follicular lymphoma. Then I have discussed about Waldenstrom's macroglobulinemia and mycosis fungoides, that is a malignancy of skin, interesting disease. So these are very low grade non-Hodgkin's lymphomas, whereas lymphoblastic lymphoma and Burkitt's lymphoma, I'm sure you have heard, it's common in HIV. They are very high grade aggressive lymphomas. And this slide further discuss the differences between the high grade and low grade lymphomas. Generally, low grade occur in older group and the high grade in young adults and children. And if you take the stage of presentation, since it's a slow growing disease, it present in the higher stage. And again, even this one, because it's rapidly growing, it is also present in the high stage. And CNS involvement is common in high grade lymphomas. And then if you do not treat the natural history in the indolent group, it is a very slow growing tumor, and the proportion will eventually, after many years, they can convert to high grade lymphomas. But if you do not treat these aggressive lymphomas, the survival is only weeks, more than months. And the interesting treatment is, although it is slow growing, it is generally not curable by this treatment, whereas high grade, although it is aggressive, it is highly responsive to treatment. So this is the good thing. The etiology is also important because most of these etiological factors we can prevent. So it is associated with genetic disease, Klinefelter syndrome. So it's a complication of Klinefelter's to get non-Hodgkin lymphomas. Infections, interesting: Epstein-Barr, HIV, Helicobacter, HTLV1 and hepatitis C. So these infections we commonly encounter, so they can cause non-Hodgkin lymphoma. Remember that. And then also environmental factors: exposure to various solvents like thinner, the toxic solvents, herbicides, wood preservatives. So it could come as an occupational disease, and also frequent use of hair dyes for cosmetic purpose can rarely leads to non-Hodgkin's lymphoma. And immunodeficiency, HIV, and it's the complication of organ transplantation. And remember, this is very important: radiation. So mobile phones, the frequent use of mobile phones, these rays has been found there is increased incidence in non-Hodgkin, especially the head and neck area. And also autoimmune diseases like Sjogren's and Hashimoto's thyroiditis can cause non-Hodgkin's. So these all etiological factors are not very rare problems. So it is a dreaded complications of all these etiological factors. Now if you take the clinical features, It is as opposed to the Hodgkin's lymphoma, where you have a very orderly and a very contiguous type of spread and a low grade presentation. In Hodgkin's lymphomas, the presentation is widely disseminated. They can come with nodal involvement. They could be painless, symmetrical, asymmetrical, like Hodgkin's, but they are of different lymph node groups. Right? In Hodgkin's, it is generally a one group or a contiguous group. Here it is you can get lymphadenopathy everywhere. And in Hodgkin's, it is the commonest is the cervical, whereas in non-Hodgkin's, the oropharyngeal involvement, that is tonsils, adenoids, that type of involvement is common in 15% of patients. As opposed to Hodgkin's lymphomas, fever and the constitutional symptoms are less common. I'm not telling they do not happen, but they are less common than the Hodgkin's, and these patients can come with hepatosplenomegaly, organ involvement. And also extranodal disease is common in non-Hodgkin as opposed to Hodgkin's, where the extranodal disease is late. So what are these extranodal? They can cause bone marrow involvement, so they can present with cytopenia. They can cause various GI symptoms like chronic diarrhea, intestinal obstruction because of the involvement of intestinal lymph node group, which is called intestinal lymphoma. They can cause skin involvement, which is called this might come in an MCQ sometimes, even in undergraduate or if you do postgraduate, mycosis fungoides or Sézary syndrome, right? And then they can come with CNS, diverse CNS, diverse presentations due to CNS involvement like meningitis, mass lesions, Guillain-Barré, etc. And then they can present with a lump, either thyroid or testicular, in the lung, pulmonary nodules, pleural effusion, and then ocular involvement also recognize presentation. So I think now you can differentiate the presentation of Hodgkin's and non-Hodgkin's. Hodgkin's, it's lymphadenopathy, fever, night sweat. Now here, the generally lymphadenopathy of different groups or some unusual presentation of due to organ involvement. Now this is a very important slide which is common to both Hodgkin's and non-Hodgkin lymphomas. It is commoner in non-Hodgkin's because of this extranodal involvement, but can occur in Hodgkin's as well. So what are the oncological emergencies occur in lymphomas? They can cause SVC or IVC obstruction due to compression. Also, they can cause acute airway obstruction because of the SVC obstruction or direct compression of the trachea and things. And then if it is intestinal lymphoma, can present with intestinal obstruction or intussusception. Spinal cord, acute spinal cord compression can be caused by lymphoma, acute ureteric obstruction, pericardial tamponade, and hyperuricemia, acute hyperuricemia due to tumor-lysis syndrome. And then they can present with a stroke or a CNS, acute CNS mass lesion or lymphomatous meningitis. So these are all a differential diagnosis in lymphomas, and also they are thrombotic disease, so they can present with venous thromboembolism. So these are these complications you encounter as a junior medical officer in future. So remember, lymphoma could be a differential diagnosis of all these complications. Okay, Now investigations. Now investigations are similar to Hodgkin's lymphoma, but the bone marrow has a better place as there is an early involvement of the bone marrow, and because you have seen there are so many types of T cells, B cells, and also the groups of these lymphocytes. So the immunohistochemistry is important investigations, and since it's some genetic disorders are associated with the non-Hodgkin's, gene mutation analysis also. Now treatment, the basic thing about treatment is indolent lymphomas, they generally respond well to chemotherapy, but the cure cure rate is less, right? So the cure, you cannot, it's difficult to cure with chemotherapy, but they respond well. For the symptomatically, they become well. But in high grade, they need very high grade and high dose chemotherapy, but the cure rate is better if you catch them at the correct time. For low grade lymphomas, now I said it takes about many years to become aggressive form of lymphoma. So if they are asymptomatic, you can do the wait and watch approach as well. So these are the basic principles of treatment in non-Hodgkin's: chemotherapy, bone marrow transplant, rituximab, monoclonal antibodies, and surgery. Now I will just brush through some of the interesting or important types of non-Hodgkin's lymphomas that you should know. The one is a type called diffuse large cell B-cell lymphoma. You should know this because it's the commonest type of non-Hodgkin's lymphoma. So if somebody asks what is the commonest type of non-Hodgkin's lymphoma, you should know that is diffuse large B-cell lymphoma. And the follicular lymphoma, it's a low-grade lymphoma, and it is important because then here this gene is positive. So BCL2 gene is positive in follicular lymphoma. The mold lymphoma, that is called mucosa associated lymphoid tissue lymphoma. You should know about this type of lymphoma as well, because it can involve GIT, thyroid, where there are mucosa associated lymphoid tissue presence. You can get mold lymphoma like GIT, thyroid, salivary gland, and it's the second reason you should know is it is associated with H. pylori infection. So it is a complication of H. pylori infection, and also it is associated with some autoimmune diseases like Sjogren disease. So this is also, it's something you should know. The Burkitt lymphoma, you should know about Burkitt lymphoma? It's the most common type of non-Hodgkin's lymphoma in childhood. It is very aggressive, and it occurs in the commonly involve the facial bones, and especially the mandible, can cause significant disfigurement in childhood. And also the second reason is it is associated with HIV and EBV. So it's a HIV associated. And then the mycosis fungoides, that is the T-cell lymphoma of the skin, and it comes in the differential diagnosis of this type of exfoliative skin lesion. So it doesn't look like a lymphoma, but actually when you do the biopsy, it is a skin lymphoma or Sézary cell. Okay, that's all I have to tell about lymphoma. So if there is any questions, clarifications, you do have my email, so you can communicate with me. Thank you.